Hello and namaste. How are you all? This is Dr. Srinidhi Chidambaram here, and I'm very happy to see all of you at the COVID Care series presented by Apollo Hospitals. The COVID-19 pandemic has thrown up another pandemic of medical terms and phrases which now everybody is so familiar with. What used to be discussed by only the doctors is now freely tossed about in social media and all over the news channels. Right from steroids to ventilators to CRP to D-dimer to remdesivir to whatnot to all kinds of words like Coradsko or T-cell immunity, all kinds of terms are now freely known to everybody, and it is great that people are interested and they are concerned and therefore have the interest to learn about all these things because the pandemic is all around us. But at the same time, what is happening now is only confusion and panic because that information is incomplete and many times it's inaccurate. But our COVID Care series aims to dispel all that confusion. And you don't have to worry, but just listen in to our experts who will give you the most factual information and the most relevant and current information so that you are safe and well during this pandemic. One such term that we are all hearing all over the place now is the black fungus. This is nothing but a pre-existing fungal infection. It's called mucormycosis. And this fungus is an opportunistic fungus, which is actually there all around us in the soil, in the spores, and everywhere. But it has now come into focus because we hear of COVID-19 patients who are either recovering or who are affected by it, also developing this disease. But there is no reason to panic because not everybody gets it. And there are certain reasons why some people develop this particular fungal infection. And though it is of concern and it is a serious illness, not everybody goes through it. And there are also certain reasons and certain methods by which we can take all precautions. So to discuss this and to discuss other conditions of the lung that can happen after somebody gets COVID-19, I am delighted to welcome Dr. Rama Narasimhan here, who's going to talk to us about this very important topic today. Dr. Rama is a general physician practicing at Apollo Hospitals, Chennai. She has an experience of over 20 years and has worked for over 12 years in the US as a hospitalist, as an intensivist, and a primary care physician. She has been practicing at the Beth Israel Medical Center, Harvard University, University of Massachusetts, US, and at the Kaiser Permanente, US as well. She is an independent medical advisor to the US Consulate, Australian and Canadian High Commissions, and many multinational companies. And she has an MD from the Harvard University, US, and has done research at the Stanford University, US. Hi, Rama, and welcome to this COVID Care series on FB Live. Very happy to have you. I know that you're very busy looking after so many COVID-19 patients at the hospital. Thanks for taking out this time to talk to us. So we will begin with a brief overview that you could give us about how COVID-19 could affect the lung and what is this black fungus? Should we be concerned about it?
Thank you, Srinidhi, very much for having me. How can COVID-19 affect the lungs? As we all know, it's primarily an airborne virus. So the most common way of entry will be through the air, through your nostrils, and therefore into your lungs. So that would remain the primary organ that's affected due to COVID. And all of us are now familiar with the pulse oximeter, and therefore, because the lungs are the most commonly involved and most predominantly involved organ, the oxygen levels are what is monitored and helps guide us as to know how severe the patient, how severely the patient might be infected or affected. The two different terms, but more severely affected. So the ways that they do get affected is the lungs, if you would like to, in simple terms, is like the fiber in a pillow. It's supposed to be filled with air. It's supposed to have some elasticity. So it's supposed to expand and relax and allow air to come in and go out. But when there are infections and different kinds of infections, the lungs no longer remain as fluffy and able to function, allowing air to go in and come out easily. And the nature or the density of the tissue in the lungs change, and therefore the oxygen exchange falls short, or the function doesn't work completely, which is what happens in COVID as well. And what we do see are a lot of different words, but like you said, the CORADS 5, the ground glass opacity. So different types of infections tend to affect different portions of the lung tissue, and therefore will be observed on the CT or X-ray in a different pattern. So radiologists who are experts in reading these kind of tests will tell us how severe, how many areas of the lung, and how what is a percentage of involvement, based on which we might assess the severity of the attack for the patient. So that is one part of it. But like we almost always sort of counsel our patients, the COVID itself is like what you would say a tsunami. It comes, the infection is one piece. What the infection does to the lungs is one piece. But the body's response, a normal response, is to fight off the infection, be it a bacterial or a viral or a fungal infection. Sometimes the body gets a little overzealous with it, and certain types of cascades makes the body's response also a little overzealous. So it needs to kind of hold in check at a point, and when it doesn't do so, too much of that is also bad, which is what is called as a cytokine storm or the over-inflammatory reaction, which sets off its own cascade of unfortunate events, which is what we try to measure or try to understand and see if there's any sense from it by those markers, the IL-6, the CRP, all those words that you'd used earlier on, that we hope would guide us to understand how severely is the body reacting. So A is the destruction of the lung tissue and a possible recovery of the lung itself, and B is the body reacting to the infection. So it's a double whammy, because the body's reaction very often goes out of control, and it sets off a lot of inflammation, which also affects other organs now. So the port of entry seems to be one place, and then the reaction that sets off all over the body tends to sometimes attack other parts of the body, like the heart or the kidney, and then we find very, very sick people. Like any infection, when the organ is weakened, it is also prey to picking up other infections, which are not viruses, but would be bacterial and rarely fungal as well.
So what is this black fungus like? How does this is of particular, is this the only opportunistic infection or are there others?
Well, there are many other opportunistic infections that could theoretically be possible, but this particular fungus seems to have sort of been noted a lot more frequently amongst many other. Usual opportunistic infections would be anything that's airborne or more common in the hospital, and because the defense mechanism of the patient is lowered, because of the drugs we use to reduce inflammation or the drugs we use to try and modulate our inflammatory response in the body, we try to tweak things up, and that we may not be exactly at the right spot. We may be a little fall short of overshoot it, and that would make you less strong in fighting off infections. And also when we ventilate patients, we remove the mechanical defense mechanism. So things, all the bugs that are floating around that normal people walking around would just fight it off, tend to be able to go in easily and set up, a nice little nest in the lungs. So there would be other bacterial infections that are possible. The black fungus is what we call as mucormycosis. It's sort of like the almost like the mold that grows on bread if you left it out, a little powdery black stuff. So it almost never grows in immunocompetent, or people with good immune systems don't seem to grow it because we have the ability to fight it off. So therefore, one needs to understand that it only happens in people who have whose immunity is depressed. It would be the worst case scenarios would be uncontrolled HIV, but more commonly diabetics who are not very well controlled, the people in whom we use steroids, and we do use steroids in our patients with COVID, and therefore very judicious use of steroids would be something that's very should be watched for and should be adhered to by physicians. Must not be a knee-jerk reaction. COVID RT-PCR positive, here's a prescription for steroid. Correct dosing of steroids is important. Even if it was indicated, you should not be overdosing them, because that would also suppress the immunity. And also sometimes, combination of things in terms of other illnesses which further weaken the immune system, the severity of the illness itself. So mucormycosis is a rare, uncommon, opportunistic fungal infection that tends to occur in immunocompromised individuals only.
But is generally, apart from COVID-19 affecting the lungs, is it that people who already have pre-existing lung conditions, are they more prone to actually get lung damage with COVID-19?
So it's a very interesting and a very good question, absolutely very good question, because there's a lot that we are also learning as the pandemic evolves. Naturally, when the lungs are already weakened by, say, asthma or COPD or old TB with scars from it, it's a weak batsman. So it could potentially, they do pick up infections a lot more easily. There might be changes in the anatomy of the lung tissue that predisposes them to hold on to bugs, which an ordinary person might be easily clearing up. There might be residual secretions that they're not able to clear off, and therefore what we call as toileting of the lungs is not so easy for them, and therefore they could be more prey to it, definitely. But in terms of what it means to them in the long term after recovery from COVID, once a scarred lung, they tend to already have an area that's weak, and then you add on the COVID, and then we hope that they don't scar yet another part of their lungs. And then, who scars how much is a very, it's not something you can predict. Everybody can scar differently. Even if it was a little scratch on the arm, you'd find some people have a very prominent mark, and some others it barely shows. So it's the same thing with the internal organs as well. So there are no methods to predict whose lungs might be scarred more than the others. So which means that people could potentially end up with more scarring than we anticipated and make them oxygen dependent in the long term. And so far, we do not have markers or ways to do. What we do is check CT scans if they're just not improving and they require a lot of oxygen, much more so after they're that the person has healed, person has gotten better, there's no other infection, all the serological markers have settled, and yet the patient keeps requiring oxygen. Then we image them again, and we actually see fibrosis, what's called a scarring of the lungs. And so we would have to start we are using some antifibrotic agents. One of them is also steroids, but cannot be used for long term. But there are other drugs that can be used to reduce the scarring. And with time, we'll know how effective they are, because you need a length of time of treatment to see if that reverses it, stops it, arrests it, or at least prevents progression. Therefore, patients don't become oxygen dependent.
So we were talking about imaging now. There's a lot of confusion about, when it comes to taking a CT of the lung. There are now people, even when their RT-PCR is negative, they go along and have a CT to just see whether there are the telltale signs of COVID there. Or there are people, so there are some doctors who say you don't need to do a CT if you don't have any severe symptoms. So, and some say mandatorily do one around the day 5 or day 6. So how does it work? And we also heard recently that CT scans are not safe to do very often, or if at all. So what is your take on that?
I'm so glad you asked this, because very often we find patients coming into the fever clinic with just the CT report and no RT-PCR even. For various reasons, for very many different reasons, not always scientific or medical, because the CT scan doesn't flag off the index case to the system as somebody who's COVID positive. So it might just have to do with convenience as well. But certainly that's not very helpful, because the number one diagnostic test world over still remains the COVID RT-PCR. And yes, sometimes we do find they are RT-PCR negative, and yet they have done a CT, and you might still find some changes on the CT, which would suggest they have what we can only label as viral pneumonitis. So if it's a good center that reports it, you would find that they would not commit to a microbiological diagnosis. They would merely state what they see. So in that itself, you should be able to, any patient should be able to realize if it's a good radiological center. They would term it as viral pneumonitis. For any infection, so the RT-PCR is a way to determine if there is the viral load or virus alive in the area that they have swabbed, which means two things: A, there is an infection, and B, that they can transmit it from the nose or the pharynx. So it answers two important questions for us. Does that person have an infection? Is the person able to communicate it to other people? So it's very important both for the person as well as public health. The question the CT answers, though, is, has the COVID affected the lungs? So that leads us to two important issues. Now, the lungs would only be affected if the virus was severe enough or the load was enough to cause something to affect. And there's always a lead time. Every infection doesn't always show up the very next day with something on the picture. So taking a CT too soon may delude you or may give you a false sense of security that your lungs are not affected. And yet 4 or 5 days later, which is usually when what we call as the radiological blossoming of the lesions or the spots would occur. So rather than doing your RT-PCR, you went and did a CT, and the CT looks fine, and you're lulled into a false sense of security, and you don't take the necessary precautions for yourself in terms of monitoring oxygen, or for others in terms of masking and being cautious, you've really not helped anybody, neither yourself nor the public at large. So it's not the wise thing to go ahead and do a CT. I suppose what would make sense is, if your RT-PCR is repeatedly negative, person keeps showing up as with low oxygen, and you really feel that this is probably for some reason being missed on the RT-PCR, it would make sense to try and do a CT. Or if a person has an RT-PCR positive and the oxygen levels start dropping, and you feel like the person is really not headed the right way, you'd like to assess the severity of the illness in terms of how much does he have, and therefore guide your therapy, you could use a CT. But by and large, just the oxygen saturations, knowing how the person looks and behaves, is enough for you to commit to a diagnosis and a treatment with an RT-PCR positivity.
Also, you were talking about the steroid use in patients with COVID. So now here the thing is, we were talking about the black fungus and other opportunistic infections and really the appropriate use of steroids. Now, again, I find that there is a lot of confusion on, I find that I know people ask me that, when somebody might be having very high sugars, why they are not getting steroid, even though they might have mild to moderate disease. And there again, there are people who resist steroids because they've read somewhere that can lead to black fungus. So where it can be a lifesaver, people like to question that. So what is it? And, or should we just leave it to the doctor to plan this out?
I think it's fair for any patient to have a discussion, air their views and their concerns, because it helps us address it and commit them to the treatments. Because if they're unwilling, it's not going to be a successful treatment. So definitely have the dialogue with your doctors. What I would tell everyone, it is even though they might be diabetics, we are using steroids in such patients, and we do find the sugars shooting up, but we have ways to tightly control it in the hospital and much afterwards when we discharge them as well. And we do keep them in close follow-up so that we are able to titrate and adjust sugars appropriately as they come off the steroids. There are rare instances also when we might even opt for high-dose steroids. Steroids are life-saving in this case, but judicious use, as you mentioned yourself. We are only using steroids when patients show signs of drop in oxygen saturation. We are not using them in every person who is COVID RT-PCR positive. So and I think that's probably why such opportunistic infections do take host to set up a little nest in hosts, because you are unnecessarily, the doctor is unnecessarily suppressing the immunity when none is required. So normal response should be that the body itself fights it off, gets rid of it, and stops right there. Only when the systems fail or overshoot it do we have a problem. High dose steroids are normally used in ICU patients, not to be used or never prescribed as outpatients. In the very rare instances where we have a severe bed crunch and the person is sitting on the fence with oxygen levels, and because we'd like to know if it is a very moderately severe disease and we're trying to tide over a bed crisis, we provide some sort of oxygen supplementation at home. And in the rare instance, we might actually even prescribe oral steroids for them at home, but keep them in very close contact, close follow-up, and monitor the treatment, and not just write out a prescription with 3 times a day of Decadron for 7 days. Is really not what should be done. So I think wise use of it, adhere to the guidelines set forth, and constantly update, because we're all updating. COVID is not something that we learned going to med school at all. And I mean, we're learning right now as we go along. I suppose the unfortunate and yet advantageous position, if you might think so, is that we are always 3 months behind the rest of the country. So we have some reference points to look up to. So yeah.
That is an advantage, I think. Is there any particular impact on smokers and COVID? Is it the same risk as what we already said about COPD and asthma, or is there some particular, like a red alert that those who are smoking should seriously consider that they are going to be more vulnerable to lung complications if they get COVID?
So definitely, I mean, smoking definitely makes lungs bad to the extent that they are not going to be elastic at all, and it leads to a condition called emphysema, which with or without any infection predisposes to poor lung function. And you add any sort of infection at all to it, they always perform poorly. They also perform poorly if you make them exert themselves more than what is comfortable for them. So and also because what smoking does is it has a chemical that reduces the immune system in the lungs. It also has heat and soot that deposits there and breaks down the feet-like projections that help clear out the secretions. So it also destroys the elasticity of the lung. So it affects the lungs in so many different ways, which means that your lung is already is like a one-legged or a two-legged horse trying to run a race for you, and it's really not a good situation. And since the scarring or the inflammatory process is started in your lungs, and there's already an element of scarring, a repair happening, clearly you would expect that the COVID patients could potentially be scar more, and therefore might come out worse off even when they do recover. So I mean, definitely a good time to consider smoking cessation at this point. And there are studies about how pollution, not just smoke itself, cigarette smoke, but also pollution in the air tends to make patients with COVID fare worse. People have been exposed to high levels of pollutants and air smog. So.
This is an interesting question, as how do people with lung disease who already have breathing issues, now if they get COVID, now how do they know whether it's just an aggravation of their own symptoms, or are they breathless, or their oxygen saturation is dipping because of COVID?
That's a great question. A lot of times we do struggle with that ourselves when we see our patients. I would say err on the side of caution, since they're already a vulnerable population, especially with the target organ. It would be wise to follow up and, maybe in such patients image a little bit more quicker than you would for the normal patient, because they may have a slightly altered anatomy or altered radiological pictures. And secondly, it also helps us gauge the thing. The funny thing about COVID is they have what's called as happy hypoxia. Patients rarely come and complain of shortness of breath. The one patient or the few patients who do say, I feel short of breath, are often not really hypoxemic or do not really have low oxygen, and they're just in a state of panic. Most of them go about with 70s, 80s, even without feeling that they are short of breath. You'd find them gasping, but you ask them, how do you feel? I feel well, in the ICU or even in the wards. So they might be coughing, hacking away. Those would be complaints, but not so quickly to say I'm short of breath. So, but that's in no way, a way for us to determine one from the other. If it's a COPD or a chronic lung problem, exacerbation, or it's because the COVID has gotten worse, the oxygen level will still remain the gold standard of assessing how bad or which way the patient is heading. So it's very important to monitor that. So all of our prescriptions go out with saying, monitor your oxygen levels at least once in 3 hours or once in 4 hours, so that you're able to. It's important for them to also understand, which is hard in India because most people go to a doctor when it's needed or use the inhaler only when it's needed, even though they're supposed to be using it every day. But I feel fine, and they don't really use their inhalers all the time. So it would be important for people to understand how they felt before and how they feel now. They're worse off. If they truly do feel worse off, they should be always checking their saturations and reporting back if it's low. One thing that we might do differently is in COPDers, we might have a slightly higher threshold in monitoring their O2 sats, in the sense that for most people, we would say 94% and below is bad. Maybe for a COPD, we would go down as to 91% because they're not great oxygenators anyways in the first place. So we might have a lower cutoff point for them, because that's how much we can expect their lungs to hold on to the oxygen or use it or trap it or extract out. So that would be the only difference, but they have to be more watchful.
There was also this thing that I read somewhere that the black fungus can also come because of inappropriate hygiene while using oxygen concentrators at home. And now there's a lot of interest in people buying oxygen concentrators and using, or at least keeping them at home. So what is that true? Or do they need to follow some precautions?
The ICMR has declined that, and it's their theory is no, it's not from. I mean, obviously, when you use anything, any equipment, it has to be sanitized. It has to be kept clean between users and between users with the same person itself. That's not just for black fungus, but for just anything. So even if I were to use any piece of equipment on myself, whether it be just an applicator or a nasal spray or eye drops, there are certain hygiene steps to be followed between the uses that I might have between morning and evening. Certainly don't use these kind of instruments easily and freely between members within the same family, hard as it might sound. At least use the apparatus. The main structure can be the same, but the tubing, piping, and mask has to be independent for each person if you're planning to use it for the next person in the family. But so far as we have understood, since it's fairly new, it does not seem to be going through the concentrators. It needs a host to build a home in. It cannot survive just like that in the air. And because if it did, then it would have gotten smarter and would have started making a home in immunocompetent people also. So it needs to survive someplace where it has food, which is some body cells.
We now will go to the questions coming live to
Sure.
us. So the first one is, how serious is the black fungus?
I mean, it's certainly something that we wish we did not have to deal with. It is different. It is a lot more than what we had before. So it is certainly something that we should be watchful for as physicians, as clinicians. We have to keep in the back of our mind. We have to use that as a reminder to not use medications unwisely. It can be invasive, and therefore we do need specialists like ENT doctors and ophthalmologists, and we will need special imaging to diagnose, and we will need biopsies or scrapings. But so far as what's been trickling in, we are seeing a lot more of these than we ever did, which is a warning sign. We are also therefore being warned to not play around with the medications too easily and unnecessarily. But we do have medications for it, if that's reassuring. There is treatment. I think being cognizant of being aware that this could be a possibility and to check it firstly in patients who have been treated with high-dose steroids, and B, not use high-dose steroids or steroids at all when it's not indicated, would be the two lessons to learn from it.
So what are the symptoms that somebody who's had a COVID-19 and who's recovering should be alert to?
I'm sorry, could you say that again? I kind of lost
I
you.
was just asking about the signs and symptoms of the black fungus, which people should be aware of and should be alert to if they've come home after recovery, or when is the crucial time when this could happen, and what would be the signs and symptoms to look out for?
So usually what we are seeing now is a lot of these cases are being reported either from the lung or from the ENT specialists, more so from the ENT specialists. So a lot of sinus type of symptoms. And it's scary when you say it like that, because almost everybody has a nasal blockage or a heavy sinus, especially when you keep using, if you're using oxygen, you've been discharged from the hospital with some oxygen, dries things out and you don't feel comfortable and it sets off a scare. But certainly something that makes you feel uncomfortable, pain, one-sided blockage that doesn't go away, a continuation or resurgence of fever, which once went away. Some people might find some redness in the eye. It would just not feel the same as a usual sinus problem. The on our lung issues, usually the patient might not even know it existed or might cough, and when they cough they might actually see black residue in it, which continues to persist even after clearing up, because sometimes if it's just the smog or the pollution, you cough up and spit and it clears up the second time, your body has cleared it off. But if it doesn't clear up and continuously appears, then it would be certainly a time for you to re-review with your doctor. And many times they image, they do a x-ray or a CT, and they see some other changes, and then they refer you to a pulmonologist who might do another procedure to diagnose it.
So which is the next question, as to which specialist should I visit to diagnose or treat this?
See, I trained in a system where everybody went first to an internist, and it's the internist's job to get it right first time. And the system is such that they don't want to be needlessly referring them everywhere. And it sort of protects the patient, because that way they have judicious use of resources, and the specialists are doing exactly what they're meant to do, rather than triaging things that are outside of their area of expertise. So I would say if you have a good family clinician, or the clinician who treated you and discharged you, go back to that same doctor, because they know your history the best. And, if it's a sinus related issue, I would think an ENT doctor is who would be able to do it. And certainly there's a lot of interest and updation and a lot of reading up that's happening. And if you really feel it's your lung related, it would be a pulmonologist or lung specialist. So I would, you couldn't go wrong with either three of them, any one of these three docs. The internist would not ordinarily check and then guide you towards the right specialist in that case.
So what are the precautions one can take? We have already discussed this about appropriate steroid use and practicing hygiene, and I suppose sugar control as much as possible.
Right. Yeah. Absolutely. And it's a good time for people to look at their, if there's one biggest truth that has come out of all of this in the last year that the world has been struggling and brought down to the knees, is at the end, everybody looks the same in those wards, gasping for air. One commodity that we took for so granted, so lightly. It doesn't matter who you are, what you are. At the end, it becomes how much oxygen, what are we doing to get them better? Everyone's sort of just on an even keel here on that one. And it's really very disheartening sometimes. And it's very humbling to see. Take care of your bodies. And that's the only other lesson we learned, that the years of negligence, sometimes people who do better are those who are healthy to start with. So I think it's important to take care of oneself.
Not sure about this question as to the nutrition plan for black fungus disease, but not sure whether
I'm not sure we have an answer for that, really. I mean, I would say just eat healthy, eat right, follow usual hygiene techniques. I mean, there was this one scare once a long time ago, 2-3 years ago in the States, when they used a neti pot, the jal neti, where, to clear out the sinuses. And people got a little lax with it, did not clear up the pots or did not use the right water. And it led to a lot of fungus too. So I think it's important not to do things to yourself unless you know what they are. So don't get overzealous with things because, people might think it's a sinus issue, so I'm going to clear it out. Wait, talk to your doctor and do things. I mean, don't take medications without a prescription. Just eat right as your body demands, in terms of how your other health conditions are, whether you're diabetic or a kidney patient. Eat right for that and stay healthy, and I think de-stress.
The CT score of my sister is 10. How severe is it in terms of lung infection?
um, to answer that question is rather tricky. As in a number, one might say it's mild, but if the person already has bad lungs to begin with, or the person has multiple comorbidities, or despite the score of 10, or you got the score of 10 on day 2, then it's probably in the stage of progression and we don't know where she will hedge. So my answer would be watch the oxygen saturation. That's going to tell you how bad or how good she is. And it's going to guide you as to what you need to be doing.
The next question is the fungus, does it also spread from person to person?
So the current disclaimer, or the current information that's been given to us is absolutely not. It doesn't. And so it only happens when the person is immunocompromised. So there is no such fear of it spreading from person to person by air like the COVID virus is.
Somebody is again asked about the exact treatment modality for fungal infections.
So if you're specifically referring to the mucormycosis, it involves the use of amphotericin and certain other antifungals. They have to be administered in the hospital under the guidance and supervision of doctors. And they are different types of vehicles in which the medication is loaded. So they're not very easy to administer, and they're reconstituted, so it requires a good pharmacy support. So it's a technical issue that your treating physician would be doing in conjunction with infectious diseases specialists, as well as the organ that's affected, if it's ENT or pulmonologist. So it'll be a multidisciplinary approach. But there are medications, they're antifungals.
This is the last question. What are the chances of a normally healthy person getting black fungus who was COVID positive and administered remdesivir and steroids for 5 days?
The answer would be slim to none. So you may be please reassured, slim to none. So that's good.
So I think that's about it for now. Dr. Rama, thank you so much.
Thank you
for sharing all this with us for a long time now. We've had a very informative and illuminating discussion. And viewers, if you have more queries, you can always get in touch with us through the Facebook Messenger or put your comments on the FB page. Thank you, Rama, for a wonderful discussion again.
Thank you very much.
Thank you, viewers, for being here. We will meet again tomorrow. And we are going to have a special episode on NCDs tomorrow, which is going to be the impact of COVID-19 on liver diseases by Dr. Mahesh Goenka, who is a senior consultant from Apollo Hospitals, Kolkata. So tomorrow, please be there. And this is an important topic too for people who are already having liver diseases. There's a lot of concern about whether COVID-19 will worsen the situation and how will they do with COVID-19. So please do join us. And for now, I'll take leave and say goodbye. Please take care of yourself and don't forget that SMS, which is the social distancing, wearing the masks, and also sanitizing. Take care. Thank you, Rama. Thank you, everyone. Namaste.
Thank you.